And since it is 12 noon, we'll go ahead and say hello and welcome to everyone who has logged on to today's CMDA monthly meeting. Happy July 4th weekend coming up, and we're so glad that you're able to take some time to join us to learn some things today. We have a wonderful lineup of speakers. I think that there's been so much going on with public policy and news from Washington, D.C. Sometimes I just want to bury my head in the sand, but sometimes I want to do something. And who better to talk about that than the people on today's call? So we'll start today with Chad Fear from the CDPHE and Jenny Albertson from CHCA. We also have Alex Bardakh with PALTmed and Leslie Eber with CMDA. So why don't we start with Chad? I see you have logged on and we'd love to hear from you.
All right. Hello, everybody. I'll just start with, excuse me, one reminder, and then I'll share a little bit of research that I did. And the reminder is the stakeholder meetings for the Chapter 5 State Rule Rewrite will be the first Wednesday of the month from August 2025 through April of 2026. These will be from 1 to 3 p.m. And there'll be an opportunity to either meet in person or attend by Zoom. So we look forward to as much input and participation in that process as possible. So as I was, as I was preparing for the roundtable meeting, I was just kind of cruising through, looking at some statistics, and it just kind of jumped out at me. How many areas are in terms of our critical element pathways. So critical element pathways are the instructions that we follow to investigate certain areas for regulatory compliance. And I noticed that there were a number. Obviously, medical director has its own tag, and then there are some highlights where the medical director should be very intimately involved in the facility process. Things like the quality assurance, performance improvement process, the QAA committee, being a member of that. But also, as we're investigating, we're asked to consider whether the medical director has played a role in vital parts of other areas. And those would include things like physical restraint and chemical restraint, accuracy of assessments, and comprehensive care planning. And in terms of accuracy of assessment and comprehensive care planning, the focus here is related to diagnoses that lack sufficient supporting documentation. So getting that schizophrenic diagnoses, the diagnosis for schizophrenia, and having that have the supporting documentation that it requires in order to really justify the use of the psychotropic or antipsychotic medications. There were some other areas that kind of jump out, and this pertains to being involved in the development of resident care policies, areas like mobility, respiratory care, dialysis, laboratory services, hospice, and of course, a very important involvement in the infection prevention and control program. It just kind of jumped out at me as I was going through how many areas that are affected through the survey process and involve the other areas to look at that involve the medical director. And I really just wanted to share those with you today.
Yeah, thank you, Chad. Thanks for always keeping us in mind, specifically this group, CMDA. There is a question in the chat box. I was going to ask a question, but Dr. Rogers has a question here. Oops, where did it go? Do you want to ask your question, Tim? Or, oh, your sound isn't working. Oh, here it goes. How do you want us to document the medical director involvement?
Right. So I think the medical director involvement, I mean, obviously it comes forward in many, many different forms and fashions. But I think two main areas are the provision and oversight of the development of policies and procedures. So ensuring that the medical director is involved in that process, signing off on policies and procedures. And then I believe the other area that is so important is the day-to-day documentation of the involvement of the medical director when it comes to resolving diagnoses, working with peer level practitioners in trying to resolve any discrepancies related to medication use, diagnoses, treatments, if treatments are in question, and getting that documented in a progress note of some form to show that interaction and the attempt by the medical director to represent the facility in resolving those issues.
I'll try to continue using those processes. And I know another question that had come up was about using psychotropic medications and informed consent for the residents. Have you had more guidance about what would be appropriate informed consent, especially if we know that there might be medication changes in the future and dosing changes? Is there a way to encompass it all so there's not a separate consent each time?
I think you have to look at the history of the person. And are these significant and major changes, like particularly increases? And does the existing informed consent cover the information that you are providing in terms of obtaining an informed consent, that I may be consenting to medication at a particular dose, but if increasing that medication were to increase the possibility that I may experience a side effect or a symptom of some sort, that you'll want to update that informed consent because I would be agreeing to a new set of circumstances, even if it's the same medication, just at a higher dose.
Yeah, maybe take some global review of that. Yeah, thank you. Well, we appreciate you keeping that invitation open for CMDA members to help with the Chapter 5 rewrites. And CMDA would love to have Leslie Eber represent us at most of those meetings, plus any other members that are interested. So if there are members on this call who want to join Chad and Leslie and the whole group, please let us know, and Leslie can connect you and make sure that you have the invitation. Thanks a lot, Chad. Hey, Jenny Albertson, welcome.
You
Thank you for being here.
bet. I have more information than I'm actually going to speak to, but I want to make sure you all have it in your hot little hands with links so that you can reference this moving forward. Are you able to see my? Yes. Okay. Okay. So since everybody has Medicaid on the mind and the mega bill, I'll get to that and give you a lot of references around that. But let's just start with some good news. If you hadn't heard already, Telegen has won the QIO contract for the next 5 years to be our quality support. In case you aren't familiar with how this works, basically CMS gets excited about something that they want to see improve, and they send Telegen on a mission. And the mission is to go out to our providers and help them with technical assistance, quality improvement, create tools for us to use, help us audit ourselves. They are a non-regulatory entity to help improve quality that is funded via Medicare dollars. So they are a huge asset to us and have been a wonderful partner. Telegen has a developed relationship with us going way back, and we really are excited that we have them back for another 5 years. So let's talk about the mega bill just briefly. There are some logical next steps, and actually this morning I received an alert that it did pass the Senate. They had an extended vote-a-rama on amendments and last-minute changes. The parliamentarian makes them adhere to certain rules, which means the things they threw in to sweeten the deal for Alaska to get Lisa Murkowski on board with voting in favor of it, those got questioned by the parliamentarian as against the rules. So, there's a lot of gamesmanship. But we're not kidding when we say mega bill. If you click on this interactive tool that the New York Times has posted, much like during COVID, New York Times seems to be the ones with the the coffers that allow them to do data analysis in the moment. And they have done a wonderful job listing all of the categories and dollar figures associated that have been predicted for both cost and benefit, or cost and savings to the federal government for each element of this bill. And it is page upon page upon page. What I did for you here is I snipped from their article as of 10 o'clock last night where we stood with Medicaid specifically for costs and savings. Next, it's going to move on to trying to pass the House. Remember, in case you aren't a politics wonk like I am, Republicans do hold a narrow majority, and under Mike Johnson, they're going to push for this to be passed because it is fundamental to Trump's agenda. And then, of course, signature of the president will be a slam dunk as long as he gets what he wants out of it. The mega bill, cost versus savings. Here's just a general look. Tax cut extensions is the major thing that they are pushing. And that is what is going to drive the national debt up much higher than anticipated. You can see that the Medicaid cuts are the largest cuts in the budget, but they don't compensate for the tax cut extensions increase in cost. It's a disproportionate calculation on their part, but most of the costs are in extensions of the tax cuts. They've also increased defense spending. They've cut environmental programs. We're going to lose our electric vehicle tax credit of $7,500. I've been shopping for them. I was like, I better get one in. Anyway, that's going to go away with this. And the majority of the savings from Medicaid that's expected are going to be for cutting benefits completely for lawfully present immigrants, meaning those that are here with asylum, temporary protected status, DACA recipients, refugees, and green card holders. Those people are considered lawfully present. They are not considered illegal, so to speak, but they will no longer be eligible for state-funded health benefits. So the changes to Medicaid and the mega bill, these are the increased costs to the government. So they've absorbed a couple of things that will increase cost, and that's here on this slide. They will be boosting Alaska and Hawaii funding because they want to get those senators to vote for it. And then begins all of the costs and or all of the savings. Costs to the Medicaid program, savings on the other side. You can see a whole lot of immigrant coverage mentioned multiple different ways throughout. There will be an addition of co-payments. There will be a limitation to demonstration projects when states decide they want to try something as a service to their population. Remember, this is a collaborative program managed with federal and state, and these cuts just keep coming and coming. This is page upon page, all the way to a $317 billion savings anticipated from the work requirements, which basically does not impact, wouldn't technically impact the majority of Medicaid recipients, since almost everyone who's a Medicaid recipient and work eligible is already working. The savings expected here is because they expect people to fail to meet the standards for paperwork compliance to demonstrate that they are compliant with the work requirements and therefore falling off the rolls. That is essentially how that is calculated. But there's a whole lot of stuff in here, and I'm going to let you read it on your own. And I encourage you to go to the New York Times page to track all the changes and machinations, because it is of the moment. It'll tell you right at the top when it was last updated. If you want to see the Congressional Budget Office calculation of what they anticipate for uninsured individuals moving forward, if this Medicaid plan goes through, there's a link here on this slide to the Congressional Budget Office. Basic summary is that they expect about 10.3 million people will lose Medicaid coverage, including, children and everybody who's on the plan. This is not just our people. Our people are a little bit protected through these cuts. The intent behind this is, of course, that they want to cut fraud, waste, and abuse. And I don't like that being tossed around when it comes to us and what we do. So I wanted to put this PolitiFact article out there for you. CMS does look internally at its own level of compliance with billing, and they see that primarily the problem is not people slipping through the cracks becoming Medicaid eligible, which just sounds frankly very silly to any of us who know how Medicaid application processes work. It is not easy to get put on the Medicaid rolls. Most of the 5.1% error rate is from inappropriate administrative billing processes, nowhere near the 20% that we're alleged to be experiencing. And then the last bits of information for your edification, there is a new rapid reintegration process for our Medicaid beneficiaries in Colorado, which is intended to keep people back in the community when they are considered at risk for becoming institutionalized in a nursing home setting. This is a very specific target population. There's detail here for you to better understand it, but bottom line is they're Medicaid eligible, they need additional supports, but they are not necessarily warranting long-term care in an institutional setting. And here's the background to where that came from with our Department of Justice settlement that caused that program to come into being. We do have a new PASR vendor. This is important for you to know because they are expecting a very extensive amount of mental health diagnosis process on the hospital part in order to get a level 1 screen passed to a level 2 in the nursing home setting. So we may see people bottlenecking in the hospital while they await a deepening mental health diagnosis. For example, when you're familiar with ICD-10 codes, right? The first code gives you your basic diagnosis. They're expecting a minimum of, I believe, 2 extensions beyond that. So you can't just say someone has major depression. We have to understand the nuance in their diagnosis, and the hospitals will be held liable for doing that in order to get them put into the PASR process. The idea behind this is that they want the social workers at the hospital to bear the brunt of this, not the PASR administration process through Maximus. And so they're not going to be sending social workers out to nursing homes in as great a volume. They're going to revert to COVID era telehealth type evaluations of people for level 2 screen. Quick little update on the nursing shortage. We are seeing improvements, although we do have a lot of folks still retiring out. So keep pumping people full of the desire to not only be geriatricians, but also to be nurses in our setting. We need it. There's just still a pretty high retirement rate, even if our burnout rate is declining. So this is an interesting barometer for where we are. And then these are our upcoming events. If you have not already gotten folks signed up for this, I would particularly highlight that we have a suicide risk in elder care training happening on July 17th. And this is, we are the second most likely population to experience suicide, elders, after adolescence. So I think it's worth us understanding it and exploring the regulatory impacts and why we can or can't take people in our setting and all of that. We'll go into it in great detail, and I've invited some wonderful experts to join me in that training. So there you have it. Thanks, everybody.
Thank you, Jenny. I always appreciate your comments and the compassion that you bring with you when you give us the updates. And we love this partnership that we have with you and CHCA and what you bring to us from ACA. I'm just going to ask the audience to, why don't you hold your questions till after our next speaker, because they're very much aligned with public policy. As you know, CMDA is the Colorado state chapter of PALTmed, the Post-Acute Long-Term Care Medical Association. And today we have Alex Bardakh with us. He is the Senior Director of Advocacy and Strategic Partnerships for PALTmed. And I'm sure we have a lot of questions, and a lot of what Jenny has just presented will probably relate to what Alex has for us. So we are so grateful for you to be here, Alex. And thank you for coming.
Thanks, Singh, and thanks, Colorado, and thanks, Jenny, because that was a great overview. So, you know, I speak to a lot of different state chapters. I could tell you, I think I'm at my highest level when I speak to Colorado for some reason. I don't know why, especially when I'm in Colorado. But yeah, as Jenny just mentioned, I think the breaking news this morning is the passage of the bill. And just to put color on it, it took a tie-breaking vote from the Vice President, J.D. Vance, this morning to cast it. Which is kind of probably, if you think back to Trump won during the dramatic vote on the previous ACA, which was the name of the healthcare bill, if you recall that back then. It was the John McCain thumbs down that kind of was the dramatic vote there, and then here we are today on this vote. But just to put color on some things that impact you all, and just to be, I am actually at the beach, so I've been trying to read this. So Jenny might correct me if I get something wrong here, but a couple of things. Number one, on the physician payment side, this has been an issue that dates back to last December when they tried to solve the cut that comes to all physician payment under the physician fee schedule. You have a 2.9% cut that's been in effect since January 1st. If you didn't know that, you haven't been getting reimbursed as much as you thought you should be. But So there's been a lot of debate as to how to solve it. The House version had a provision to tie it to the Medicare Economic Index, which is a long sought after policy to have automatic updates to the physician payment. So we don't have to go through this year by year. But that was changed in the Senate. First, it was stripped out. And then I just was looking just to make sure there is a temporary fix of 2.5% for 2026. You have to remember that everything that was in the House bill that was passed was subject to what is known as the Byrd Rule, and I think Jenny referred to this. And the parliamentarian had a lot of power to remove provisions that the parliamentarian felt like were not related to sort of the tax provisions that could be done through the reconciliation process. So there was a lot of arguments what should be and what should not be included. So, obviously there were things needed to be changed and or taken out to comply with what's known as the Byrd Rule. And so everybody was watching that closely. And to put a fine point on an example of that was the staffing mandate, the nursing home staffing mandate. So this has been challenged in the courts, as you all know, but it's also been a focus for this piece of legislation because, as you saw, sort of the added costs and the savings, the staffing rule had a tremendous amount of savings, and so they were looking to repeal that to find the dollars to pay for the increases. And so at first it was in the House version, then it was taken out by the parliamentarian because of the violation of the Byrd Rule. And so they went around that by actually delaying its implementation for 10 years. So my understanding, and again, Jenny, correct me, is that it is in the final Senate version is a delay for 10 years. So essentially it's another way to kill it. And it's still, of course, going through the courts. So those are the two major things. The other one that was on that big list from the New York Times is the provider tax. That was a big one. There is an exclusion for nursing homes in there, but the way that they collect Medicaid funds through the provider tax has been reduced. And so there's a thought that, if overall they're not able to collect Medicaid funds with matching federal dollars, there's just not going to be as much reimbursement on that side. So again, it's going to take some time to figure out how it's all going to actually impact everybody as these bills go. I mean, their implementation is a huge part of what happens here, but we do know, and then the rest of it, obviously the concerns around people that are losing coverage under Medicaid, as Jenny covered, is going to be something to watch, and I think it's going to be a subject of a lot of debate. We have, politically speaking, of course, we have the midterms that are now that we pass this bill, what's going to happen is that everybody's going to go back to their districts, and if you're on the Republican side, you're going to try to defend it. If you're on the Democratic side, you're going to try to attack it as much as you could. If you remember back to the days when the ACA passed, it was very kind of similar. Everybody went back to their districts and their corners, and depending on which voter you were trying to get, your messaging changed. And so we're going to hear a lot about what this means and in the districts, and I think that there's going to be a lot of people who are going to listen. We've already seen what the town halls have looked like, and I think we're going to see a lot more of that. And so the midterms that are going to occur are going to tell us a lot about how the public perceives what's in this bill and what they think about it. And I think, obviously, if the House does flip in the next at the 2-year mark, it's going to be interesting to see what happens. It's very difficult to reverse these kinds of laws, as we've seen with the ACA. The Republicans have talked about getting rid of the ACA for now 15 years, and I think they've kind of finally given up, although they've kind of chipped away at it through this bill in many different ways. So, that's kind of likely what we'll see. The final analysis, I'm sure, there's going to be a lot of postmortem. This just happened this morning, and the House, as Jenny said, still has to take this up. There's still some work to do. I mean, if you were betting on this and you didn't bet the House passing this and getting it to the president's desk, I'm not sure, you'd be a smart person, because they've delivered every time. Mike Johnson has delivered for his conference, and the Senate's done the same. So they've been able to figure out politically how to make it work. And I have no doubt that they'll do the same now with the House version. But procedure is important here, and they do have to, reconcile this and pass it in the House. From what I see, they are scheduled to take this up tomorrow. So I don't think they're going to be wasting any time. They had a imposed deadline of July 4th, and I think they're speeding through to get there. And as you all know, well, you might not know, but August is a month where there is a congressional recess, and that's the time to really go back to their districts and hold town halls or whatever it is. So, they want to get this wrapped up. They want to get their messaging together. They want to figure out, go on TV, do all those things that we know that they do, and try to figure this out. So that's kind of what's going on the latest on the congressional front. For PALTmed's part, we did participate in this process. We signed on to a number of letters expressing concern about the Medicaid cuts. We signed on to several letters about the physician payment issue, which, I would say, I don't think it's a victory. I think it's a very temporary, once again, kick the can down the road type of victory. And there's going to be a lot of conversations on how to have a permanent fix that everybody seeks. There are still outstanding issues on prior authorization, 3-day stay. There's a number of other things that are out there that were not addressed in this bill that are going to be part of extension talks in September. Remember that there's still the reconciliation process to fund the federal government. Things like, for example, like telehealth extension. This was not in this bill. It expires in September, and nobody wants to see telehealth go away. So what's going to happen with telehealth is another kind of provision that we'll see tackled. The other big news that I think that happened this last week was the removal, the installment of new ACIP. That's the Infection Prevention Board. So we had a removal of each and every member, an installment of very different type of members, and they held a meeting to recommend their vaccine coverage for the fall. If you've read the news, I don't know how to put it, how that meeting went. It was a bizarre meeting, to say the least. I think we saw presented a lot of what we know RFK Jr. and the folks that he supports are putting out there on blogs and podcasts and YouTube videos. All of that became very mainstream. You all know the infection control, the technical aspects of it far better, but essentially there was a lot of questioning of effectiveness and all multi-dose, all kinds of things. And so I think there was a lot of concern of what's going on with ACIP and, what it will look like moving forward. PALTmed signed on to multiple letters expressing concern with ACIP. Obviously, we want to see geriatricians there. We want to see science. We want to see evidence. We don't want to see, my grandmother told me a story of, how my finger fell off when I got vaccinated. I'm exaggerating, but there was some of that. A lot of people felt like there was a lot of that present at the meeting. And yes, thank you, Leslie. We did make our own statement as well, and I think that fight is not over. Obviously, vaccines are a huge part of this, and how RFK Jr. handles it will be interesting. We're also, the CMS is kind of back on track. They have Dr. Oz as their new administrator, and they should be getting back to business. We know that the new surveyor guidance went into effect. There was a question about informed consent and psychotropics. That's a big issue, how that's going to be implemented. Obviously, we haven't heard much from CMS since the new surveyor guidance went into effect. It was not delayed. And so we'll see. I don't know if you all have seen that in your buildings, but the implementation of the new surveyor guidance will be a big deal. And the increased engagement and role of the medical director. So we'll see. That's something we're monitoring as well. The other part is that we've been working on is medical director transparency. That has to do with the reporting of medical directors, all nursing homes. It was not addressed in this bill in any way, thank goodness. But ownership transparency, that whole transparency initiative, that's something that I'm sure in their sort of phase of deregulation that they'll be talking about. But the medical director provisions remain in effect, and so CMS is collecting that data. But the way they're presenting it is atrocious, to put it mildly. And so we're pushing CMS to present it in a much better way so that the public knows who the medical directors of nursing facilities are. If you've heard any of our updates, you've heard us talk about this. So we're still talking to CMS. We're still talking to our Hill contacts about this, and hoping that CMS will not only collect information about medical directors, but make it publicly available in a way that doesn't take 3 IT geniuses to figure out. So you know, those are kind of the big things. We are resuming our meetings with CMS. Leslie's on, she's part of our board, and she's going to be part of those meetings. And so we're hoping to, resume our regular conversations, regular advocacy, et cetera. The other thing I'll tell you about, number one, is I don't know if you listen, and I apologize, I didn't have slides today, but if you listen to our podcast, the chair of the PALTmed Public Policy Committee, Tim Holohan, and I do a podcast, and we cover a lot of these topics in sort of this kind of format, short format conversation. And we want to welcome, of course, our new vice chair of the PALTmed. Singh, do you know who that is?
I've
It's
gotten wind of it.
I've gotten wind of it. It's Dr. Palat's going to be the vice chair of our PALTmed Public Policy Committee. So that's fantastic. We're glad to have her on board. And so she'll be clued in. And lastly, what I'll cover is our first annual Advocacy Summit in October 27th, 28th. And that will be in Washington, D.C. Registration, I'm happy to say thank you, Singh, for putting that registration link is now open. Please go check it out. The goal there is to have a 2-day program. The first day is focused on education, preparing you for these meetings, understanding the issues that we will tackle, how to talk to your members of Congress, what to expect, what not to expect. So if you would like to do that, I would highly, highly encourage it. As you can tell, this is a time when a lot of members are on the fence about a lot of different things. Believe me, I've done this a long time now, and what you see and hear on TV, even their public statements, is not necessarily what you see and hear when you talk to their staff or even themselves in a very different circumstance. So I think you'd be surprised of how well even a meeting could go, even if it's somebody that you think, my goodness, I've never agreed with one thing that individual said. You'd be surprised how well a meeting could go, because I think it's our job to continue to advocate for our patients and our mission, despite what we may perceive or we may see policymakers doing. So whether or not they will take our word, whether or not they will do exactly as we say, maybe not. But I think it's a long-term plan, and it's a long-term relationship that you can build that can be positive. So I would highly encourage you to check it out. We'll get you ready. You'll have a lot of fun on the Hill. And yeah, if you've ever participated with any other Hill Day, you'll kind of already know. Talk to your colleagues, and if not, please register, and we'll see you in DC. Saying I'll probably stop there. That was a lot to cover. So happy to answer questions.
That's great, Alex. Thank you. This is, a lot of our CMDA members are, of course, PALTmed members, and we hope to increase that percentage and that number. Is the Advocacy Summit open to all PALTmed members, and do you have to be a member?
You do not have to be a member. There is a fee, as you will see when you click on the link. And it actually, I believe there's no difference even in cost, because we are trying to get as many people as possible. And I think you'll be so impressed. If you're not a member, I think you'll be so impressed with the group of people that you'll be surrounded, that I don't think you'll walk away thinking I shouldn't be a member, because I think you'd find this is your tribe, as they say.
Mm-hmm. Great. Looks like Dr. Reitman has a question. And Les, you are muted. We can't hear you. Yeah, you're still muted.
There we go.
Oh, there you go.
There we go.
So thank you very much for all this information. Is this an in-person meeting in October, or is it also going to be Zoom? It sounds like it's going to be in person, visiting with the Congress people.
Correct. Yes, it will be in person. We are hoping that we get a good amount of folks and go to Capitol Hill and as they say, strengthen numbers, right?
Yeah, well, I certainly would like to do that, because I'm so tired of sending messages in. I was a little late this morning, but anyway, one question: is there anything in the bill addressing the sneak attack of Dr. Oz on the privatization of Medicare? And there was a small group of GOP doctors in a caucus that I saw in one of the web pages about wanting to increase the control over the rate estimations. I don't know the proper terms, but for the Medicare Advantage companies, it was limited to 2.2%, and now they just got 5.2 or 6.0% raise. Is there any, that wasn't even mentioned, I suppose, in the bill, right? This is for
So that's
Medicare
not, that wouldn't
Advantage.
be part of the tax bill, but we do know, so you have to take this bill, the tax bill, separate because it's part of the reconciliation processes. And I mentioned there are pretty strict rules of what could be in and what could be out, and the way that you have to phrase it. So the whole MA, expansion, if you will. So we knew coming in that Dr. Oz was favored MA through his statements previously. So the GOP Doctors Caucus is one that we communicate with regularly. They've had a lot of folks that left, Mike Burgess out of Texas. From Indiana. I'm blanking on names right now, but so there were folks on that caucus that had been long supporters of physician payment issues and all kinds of things, and they have left. So there's a lot of re-educating that's going on and kind of reconfiguring of that caucus. You have pharmacists on there. Buddy Carter, who is a pharmacist from Georgia, he's actually a chairman of the health subcommittee. And he's well aware of the long-term care kind of angle of things. So yeah, we're talking to all those folks about what's going on with MA. The big thing in MA is prior authorization and trying to fix prior auth issues around MA, because it's gotten criticized and scrutinized to a pretty significant extent. So no, it wasn't part of that bill. I'm not sure about the rate setting of MA. I'd have to look at that. I'll be honest with you, I haven't seen or looked, so I'm not sure what the percentages are. Maybe somebody else knows. But yeah, clearly I think that there's favoritism of MA, but there's a lot of criticism as well, given the concerns around the way that given the way that prior authorization works. I will say that one of the other interesting parts of the current bill that just passed was the prohibition of regulating AI for 10 years. You even saw the Marjorie Taylor Greene, who I would say is a Trump supporter, kind of come out against it when she kind of said, "Oh my gosh, I didn't realize that this AI thing was in the bill. Maybe we all should read it." That was taken out actually. So, and the reason I kind of point to AI is because AI in Medicare Advantage and prior authorization has been subject to a lot of conversations, and then the fact that AI is being used to make a lot of health coverage decisions, and so there's a lot of concern about that, and there's a lot of folks who want to prohibit the use of AI in these kinds of decision making on healthcare.
Yeah, thank you.
Well, thanks.
Mhm.
Good information. Thank you.
No problem.
And someone asked a question through a private chat about the cuts to Medicaid, and what impact do you think that could have to our long-term care residents?
Well, I think we'll see, but obviously a lot of people losing coverage. I think not only the residents, but we have to think of staff who may be Medicaid eligible, who work in nursing homes, what that means for them. You saw Jenny point out that it's lawful. I forget the term, but so it's going to be a number of folks that I'm sure you'll hear the talking points from the Republican side that have already been out there, which is that they are trying to cut fraud and abuse and only ensure that those who should be eligible are receiving the benefits, and that's the way that they're solving that. But obviously, I think there's a lot of concern that there are a lot of people that are going to lose coverage, and there are estimates of just the number of people that are going to lose insurance. I think it's at 17 million. I think I just read somewhere. This was 5 minutes before the call, so don't quote me there. But I think there's a lot of concern about what's going to go on with Medicaid. It might not be the residents, but it may be some there as well. But the other part of it is what's the Medicaid reimbursement to facilities that's already low. I mentioned the provider tax issue. Although nursing homes are exempt, or there are some exemptions for nursing homes. As I mentioned, overall, that could be a big issue in the way that states collect, because I think we'll have to see how the states, what their budgets are going to start to look like as they view impact of the provisions, because if states feel deficits, they'll have to make cuts as well. Here in Maryland, we see commercials every other day about our governor and what they have to do, and the budget that he put forward to the Maryland legislature actually didn't pass because there were a lot of concerns. So I think it's to be seen, but I think I think there's a lot of room for concern and to make sure we monitor. And I think that speaks to the need for state vigilance and advocacy as well.
Are there any other questions for Chad, Jenny, or Alex? We thank you all for keeping us in the know and helping us stay vigilant. In the time that we have left, we have two more presenters, Doctors Leslie Eber and Sophie Clark. And Dr. Eber, as you all know, is the immediate past president for CMDA. She is also the president-elect for PALTmed. We are so lucky to have you here in Colorado, Leslie. And speaking of some of the podcasts that Alex just mentioned, the public policy podcast for PALTmed, their last guest speaker was, in fact, Dr. Leslie Eber. So I encourage you to listen to that. But Leslie has some updates to us of a different nature today. Go ahead, Leslie.
Thank you so much. Thanks for having me, of course. I'm just going to share my screen and hope it works. So I have the honor to be part of the Colorado Dementia Partnership. We do a lot of work that we hope that will help providers and facilities in their caring for patients who are struggling with dementia. So we just published this about 2 weeks ago. It just was released. It's an updated family, patient, and even staff member, as well as for social workers, really for all of us, an updated patient family letter to understand psychotropic medication use in nursing homes. And so this is really written from the perception of the average person who may not know what a psych farm meeting is. And I wanted to share it with you. It is live right now. You can get a copy of this and share this with your facilities and your colleagues on the CMDA website, cmda.us. And so that's a great way to get it. And I see that Singh already put that in the chat. Thank you so much, Singh. So I thought I'd review it to show you what's in this letter. It's short and sweet, but I think it packs a good punch. So it talks about our mission in post-acute and long-term care to provide that highest quality of life for our patients, and not only quality of care, but quality of life. We then turn to talk about what is a psychotropic medications. It's not just antipsychotics, it's not just Haldol or Seroquel or Zoloft, but there is a long list of medications that can cross that blood-brain barrier and affect people that we're caring for. It can increase confusion and increase falls. And so this is a good list. This is also a great list to use for social services, for the psych farm meeting. All of these types of medications should be reviewed in your psych farm meeting. And so that's something that you should be aware of as well. And so we give a little bit of history about antipsychotic medications and when they are used and how they're not as effective when we're not using them for psychiatric medications. So when we're using them for dementia-associated behaviors, we know from a lot of studies that they're not very efficacious. And this is also explaining this to patients and families. We talk about the side effects, and it's really important. We've added that in our update, some additional side effects to make it more complete. And then what we also added is some non-medication interventions. So we always talk about non-pharm interventions. Well, what are they? What should we think about? And this way, not only do we know, and we can bring this to our psych farm meetings, but patients and families can also incorporate some of these ideas for their individual loved ones. So maybe their loved one really loves to be involved in the kitchen in putting together silverware or napkins. And they could say, oh, that's a purposeful activity. I think my dad would really enjoy that. He always worked in the restaurant business, and this is something that would resonate with him. Maybe a patient really loves jazz music, and that always calms her down. So then when patients and family members read this letter, maybe they can help us with some further non-pharmacological interventions. And then we talk about dementia-related behaviors and what that looks like and what patients and families can expect. And I think that framing the conversation to how long will these behaviors last? Do they ever stop? And so this can help educate patients and their loved ones. And then talking about the psych farm meeting, so that if we put this letter in our admission packets, which I hope everybody does, and we also shared this, CDPHE, and Chad was gracious enough to have us share this with the CDPHE Nursing Home Roundtable discussion that just happened right before this. And so not only are we all receiving this, but all the facilities are receiving this letter as well. And so if we can explain to folks what a psych farm meeting is, why do we do this, and what can you expect, so that when you as a provider go and talk about trazodone and why we are decreasing it, you can also know that this letter is available to translate some of that conversation. One of the other things that we put here, not only our acknowledgement that this is from the Colorado Dementia Partnership, and it is supported by CDPHE as a standard of care, but you can actually, with this PDF, and I have to thank Jessica on the call today, you can put your own contact information. You can add to this PDF and say, please contact Jenny at this phone number, so you can individualize it for your facilities. And you can even, as a provider, also provide some contact information about who you can ask questions if you have some questions or concerns about these medications. So I'm so excited that this is updated. It is concurrent with our regulations in May and June, or I guess July of 2025, but we finished this in May and June. And so it is completely concurrent with the regulations that we see today, including the possibility of using Resulti. So we changed the language to match the regulations, and I think that that will be very useful because people see commercials on television and they may ask you about different medications, and this letter still holds up. Do you guys have any questions about this new tool and how it might be useful, or any questions in general?
Yeah, congratulations. It looks like it would be a very helpful resource for explaining to families and other stakeholders. I have a question under the psychotropic medications. What do you recommend that we review for when someone's on a seizure medication,
I think that's a great
specifically
question.
for psychotropic meeting?
I'm about to say, well, first, you need to clarify why it's being used. What is the associated diagnosis? And then we have to look at the side effects. You know, gabapentin and Lyrica have a multitude of side effects, and I think that risk-benefit really comes into place. How is this individual doing on this medication? Is it working? Would we expect it to work? There's a lot of off-label use for some of these medications for anxiety and depression, but there's no FDA regulation that shows that that's efficacious. It's really off-label. And then balancing that with the side effects, sometimes with gabapentin Lyrica, not only do we see confusion and increased falls, but lower extremity edema, which is something that we don't often talk about. And people with congestive heart failure can have an added challenge and maybe a side effect that's not tolerable. And so I think that folding that into the conversation is really important. I wonder if anybody else would like to add to this conversation and what you think that that conversation should be when people are using gabapentin, Keppra, and Lyrica. Anybody else can unmute if you like.
I'm not practicing in nursing homes, but I remember that was what this is a huge piece of information. The question is, how well will it be implemented by every busy nursing home? But this is like the reason people are in nursing homes half the time. And so this is really good facts that people will, but it takes the education part of this with the families and the staff is super important. And thank you very much for doing this. I mean, it's been a need for years. Appreciate it.
Thanks. Anybody else want to weigh in on this new tool or on the conversation with seizure medications being used for psychotropic or antipsychotic reasons? Okay. Well, thanks, Singh. I also just wanted to add one other plug. First of all, if you have not done a Hill Day, I've done this before with Dr. Singh Pallet, and it was an honor, and it's really interesting. It is something that is so rewarding. being on the Hill and really bringing home our personal experiences with patients and communities, it really resonates. It's a once in a lifetime opportunity. I really highly recommend everybody considering coming to our Hill Day, because I've always felt really lucky to be a part of it, and now it's open to everybody. One final thing is we have our PALTmed annual conference. I know it seems like miles away. It is in March 2026, but they're going to be opening up for ask for abstracts for presentations at the PALTmed 2026 annual conference in July. So please look for it and think about whether you might want to present at the annual conference. This year it's in California, so it's pretty close, closer than it almost ever is. We're usually headed to the East Coast and crossing past a lot of time zones. And this is like an hour and a 15-minute plane ride, so much closer. And California in Disneyland. So I encourage people to think about whether you want to present. It's a great opportunity. You get a little discount and can bring your family to Disneyland. So there are multiple wins, something to consider. Thank you, Singh.
Thank you, Leslie. You make it sound much more fun than I would have. So that's wonderful. And we can, once we get that information, maybe we can email blast it out to all the CMDA members.
Yes, thank you so much.
Thank you. Hi, Dr. Sophie Clark is here with us. She is the medical director at the Veterans Community Living Center at Fitzsimmons. She also is on faculty at the University of Colorado. And she's here to give an announcement about how we can be involved in precepting fellows. Hi,
Hello.
Sophie.
Hello, thank you so much for the opportunity to talk about this. Like Singh mentioned, I do work at the University of Colorado, and our palliative care fellows have started getting their long-term care experience with us. And I was looking for volunteers who would be interested in hosting a palliative care fellow to get experience in the community, in a community nursing home. So really looking just for exposure. They counsel patients a lot on what it looks like to go to subacute rehab or a nursing home, but they don't often know what that looks like and what the experience looks like. So there's about 5 fellows. And over the course of the year, I was hoping to have them visit a nursing home twice for about a half a day. And typically it would fall on Thursday mornings, but certainly have flexibility around that. So if you're interested, I put my email address in the chat. So please reach out via email, or just if you leave your email address in the chat, I can reach out to you. So thank you so much. The palliative care fellows are awesome. And I feel like spending a day with them will like make you have hope about the future of medicine. So yeah.
Thank you, Sophie. Now, are you looking for people who are specifically medical directors, physicians? Can our PAs and nurse practitioners also host?
Yeah, absolutely. Any and all of the above. Yeah, PAs, fellows, just really getting them into the building is the most important part. So yeah, we would absolutely love them to work with our excellent PAs and NPs, medical directors, anything like that.
Well, thank you for sharing that opportunity. And I see your email in the chat box. Make it really easy to reach out to you. And Dr. Clark will also be presenting on Journal Club on Thursday, which is 12:30 to 1. So we will see you again at that time. With the last few minutes that we have, Dr. Horton and I thought we could open up a discussion like we did for the last meeting for a medical director Pearl. And one thing we've been talking about is how to get these education and educational resources that we talk about on the meetings like today out to providers and people out in the field. So Dr. Horton, would you like to share any innovative ways that you're sharing education with providers that you work with?
Thanks. Singh, I'll go really quickly because we just talked about this morning, but that was an excellent presentation. Leslie, we really appreciate it and need information like that. So I just have 2 soapbox things, and then I'll share a quick pearl. I always remind providers, routing providers, that they are the experts in long-term care. It's not the hospitalists that put them on all these meds. And sometimes it's not the community geriatrician that's not working with the pharmacist, that's not working with a team of people. So I always stress with people, even in my buildings, even short-term people that come in, I remind providers that this is the one-time opportunity that we may be able to correct something that's been going on for far too long. And one of the things that I've done recently is I pulled up the Magellan scorecard. It's the nice score sheet, and it has also side effects and references. And I actually scored a couple of patients, and then I gave that to the provider. The provider was really excited. I said, here, give this to the patient, whether they make changes in the short time period or they take it to their PCP and say, hey, have you seen this? What's up? And one of the scores was 11, and the other score was 7. So these are really important. I've mentioned it to several providers. They've liked it. I've emailed them the form. And I think that's something that you could do real time and give the patient, at least plant the seed that maybe they could do something differently.
Good. I'm glad to hear that that has been well received. Yeah, thank you. Thank you for sharing that, Chris. And one thing I thought too was, I see you on the call, Dr. Janae Durgans told me that sometimes she takes the slides from these CMDA presentations and presents them to her QAPI meetings and to her teams. We appreciate you doing that. Janae, I don't know if you have any comments or pearls on how else you get the word out and educate people that you work with, or anyone.
Yeah, thank you, Singh. That's the biggest thing, is that there's a lot of this information that the facilities can learn from, or to other things that they can be prepared for. And then last month, I took stuff from the annual meeting actually, and did educations, talked about marijuana in nursing homes, and gave the Dr. Rye's wound care presentation and helped just educate the staff at that level. And then when we have our groups provider meetings, I share that information as well.
Wonderful. I hope that that's well received and people are listening to it and taking it to heart.
So they tell me.
You're very convincing.
And a lot of the times, especially when I get this legislative stuff, and granted, I don't understand it all very well, but learning it every month that we talk about it helps a lot. But then it generates a lot of conversation in my facilities, which is always good. So
that conversation's huge. Yeah. Thank you so much. Anyone else? Well, thank you for joining CMDA today. We'll see you on Journal Club this Thursday. Have a great week. Bye-bye.
Thanks, Singh.
Thank you.